All right, guys, welcome back to Underground Science. In this video, we'll be talking about Sjogren syndrome. Okay, so before we get into the pathogenesis, we should know that Sjogren syndrome is an autoimmune disease. Okay, so your own immune system attacks your exocrine glands, like what? Like your lacrimal glands, right? And what do your lacrimal glands do? We know your lacrimal glands secrete tears, right, to hydrate your eyes. So if your lacrimal glands get attacked, then you can't secrete tears anymore, so you have dry eyes, right? Or keratoconjunctivitis sicca. And what also happens is you get autoimmune destruction of your salivary glands. If you can't, if your salivary glands are destroyed, you can't produce saliva, so you're gonna have dry mouth. Okay, and as we'll see in a moment, this this disease, right? It's a type 4 hypersensitivity reaction because it involves your T lymphocytes attacking your glands. Okay, so it's a lymphocytic infiltration, which leads to fibrosis. That's why it's a type 4 hypersensitivity. And we'll see that in a moment, okay? So let's see how this works. All right, so let's get started, see how this works. So let's say, right, this cell right here is our lacrimal gland cell or a salivary gland cell. And some virus, right? Let's say in this example, we're going to be talking about the Epstein-Barr virus. Let's say the Epstein-Barr virus infects your lacrimal gland cell or your salivary gland cell, right? And that leads to destruction of your cell, of your salivary gland or lacrimal gland cell. That's going to release intracellular antigens, right? If you get intracellular antigens released, right, what are some of those antigens? Remember, we talked about damage-associated molecular patterns, right? So DAMPs and PAMPs. When we talked about PAMPs, when we talked about like, pathogens, but your own intracellular antigens, right, can be certain DAMPs, right? Like what? Like heat shock proteins, ATP, and so on, right? So let's say we have some of those intracellular self-antigens that get released due to the damage that the Epstein-Barr virus did of the cell, right? Our white blood cells can recognize these DAMPs either through certain pattern recognition receptors like toll-like receptors or nod-like receptors, right? So let's say our macrophages recognize these self-antigens, right? Due to the destruction of our glandular cells like our lacrimal glands and salivary glands. It's going to phagocytose these self-antigens, right? And present that, right? Break it up and present that on MHC2. And then afterwards, right, let's say we have a nearby lymph node that our macrophages or antigen presenting cells can go to, right? Let's say these macrophages reach our lymph node. And in our lymph node, let's say we have T cells, right, naive T cells that escaped central tolerance in the thymus, right? Remember we talked about central tolerance in a previous video. If it escapes central tolerance, that means it's self-reactive, right? So if we have a self-reactive naive CD4 T cell here in the lymph node, and it encounters a macrophage, right, that has a self-antigen on its MHC2, then they can bind each other, right? So the naive CD4 T cell that's self-reactive can bind to the self-antigen via its T cell receptor. And this macrophage, of course, as we know, is presenting that self-antigen onto MHC2. And then we know that this is a naive CD4 T cell. So we're going to have a CD4 protein that's bound to the MHC2. And then remember, we need our second main signal, which is our B7 on our antigen presenting cell, binding to CD28 on our naive self-reactive CD4 cell. Once this interaction happens, we activate our CD4 T cell. But remember, this isn't a normal CD4 T cell, it's a self-reactive CD4 T cell. So if your self-reactive CD4 T cell gets activated, right? But before we talk about that, what else do we need to activate these T cells? Remember, your antigen presenting cells release certain cytokines. So it's going to release certain cytokines like interleukin 12. Well, remember, if naive CD4 T cells encounter interleukin 12, it can stimulate these naive CD4 T cells, right? To do what? To differentiate into Th1 subtype, the Th1 subtype of our CD4 T cells. Okay, so it can differentiate into the Th1 subtype, okay? And this is going to be a self-reactive Th1 cell, okay? So we're gonna have self-reactive helper T cells, but the Th1 subtype, due to interleukin 12 released by your what? Antigen presenting cells. Now, this macrophage or antigen presenting cell can also release interleukin 6, which can stimulate your naive self-reactive CD4 T cells to differentiate into T helper 17 cells, right? The Th17 subtype of your CD4 T cells. So now we have two subtypes. We have a bunch of Th17 cells and a bunch of Th1 cells, right? But these cells are self-reactive. So we have self-reactive Th1 cells and self-reactive Th17 cells. Okay, so why is that bad? So again, we have self-reactive Th1 cells, self-reactive Th17 cells. Now, that means that all of their T cell receptors can go and infiltrate, right? These self-reactive Th1 cells and self-reactive Th17 cells can go and infiltrate your salivary glands and your lacrimal glands, right? Because these T cell receptors can recognize self-antigens there. So if that happens, that's why we call it a type 4 hypersensitivity reaction, right? Because driven through lymphocytic infiltration of your glands, particularly your T cells, right? So you have self-reactive Th1 cells that will go and 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 recognize your self-antigens in your lacrimal and salivary glands. And when they do that, right, they get activated and release interferon gamma, as we know, and interleukin 2, right? Well, interferon gamma can attract and activate macrophages to that area. In this case, we're talking about the salivary glands or your lacrimal glands. So more macrophages means more inflammation, right? And if you have continued inflammation like this over and over, you start to get fibrosis of your lacrimal glands and your salivary glands. And if your Th17 self-reactive cells are there and getting stimulated, right, in your lacrimal and salivary glands, they can release interleukin 17, which attracts neutrophils to that area, in this case, your lacrimal and salivary glands. We know neutrophils do what? They release enzymes like proteases and reactive oxygen species, right? And that also induces destruction of wherever that's happening. In this case, your glandular tissue, right? So this is how you get, this is why it's a type 4 hypersensitivity. You get infiltration of T cells like Th1 and Th17 that go to your salivary and lacrimal glands and destroy that glandular tissue, which means those glands can't work anymore. So if you destroy your salivary glands, you get what? Dry mouth. If you destroy your lacrimal glands, you get dry eyes. Okay? So that's the basic mechanism of um, how the pathogenesis of Sjogren syndrome works, right? So again, what did we see? We saw destruction of our lacrimal and salivary glands. If you destroy your lacrimal glands, you can't produce tears, you have dry eyes. Okay, and what can you see with dry eyes, right? We know tears are good for hydrating your cornea, hydrating the cornea of your eyes, right? So if you are not producing tears anymore, you can't hydrate your eyes properly, so you have an increased chance of getting corneal ulcers. Okay, and then of course you can have blurry vision too, because you tears are good for not having blurry vision, right? Especially you can have things like, oh, we already know dry eyes, but you can have gritty eyes, burning eyes, right? Due to the lack of tear production. Even photophobia can be there too, right? And then if you destroy your salivary glands, you get dry mouth, right? And then you can also get difficulty swallowing because if you have dry mouth and you try to swallow, it's hard to swallow, right? You can also get dental caries or also cavities, right? Because why? Because saliva is important for fighting off for neutralizing bacteria too, right? In your mouth. So if you don't have saliva, you have increased chance of getting cavities, or also known as dental caries. And then you can also get certain infections, right? Like candidiasis, because again, saliva is good at neutralizing pathogens, right? So if you can't do that, you can get increased chance of, or you can have more infections like candidiasis, right? So so that's that. And of course, if all this is happening, let's say in your parotid gland too, right? Because your parotid glands secrete saliva also, right? If all this is happening in your parotid gland, and remember what's happening with all of this lymphocytic infiltration. You're getting a lot of inflammation, right? And we know with inflammation comes swelling. And we also said fibrosis occurs, right? Because chronic inflammation like this can lead to fibrosis. So due to the lymphocytic infiltrate, all these T cells that are infiltrating your glands, your salivary glands, lacrimal glands, your parotid gland, right, which is also a salivary gland. Your parotid gland, right, due to the inflammation, can start to swell. So you may see swelling of your parotid glands. Okay, so that's the main glandular manifestations of Sjogren syndrome. Okay, so let's talk about. I hope that made sense. All right, so let's talk about the antibodies that we see here because we said this is an autoimmune disease, right? So the main antibodies to remember, right, are ANA, anti-SSA, and anti-SSB antibodies. But let's talk about how anti-SSA and anti-SSB antibodies form first, right? So remember, we have self-reactive CD4 T cells. So remember, let's see that reaction. Let's see that interaction again, right? So we have self-reactive CD4 T cells. Why are they self-reactive? Because they escape central tolerance, right, in your thymus gland. Okay, so that means that they can react to your self antigens. All right. So then they have this T cell receptor that didn't undergo proper training in your thymus gland, which led to the escape of these self-reactive T cells. And now this T cell receptor can interact with self antigens, right? Like what antigens? Like SSA antigens and SSB antigens, right? Which are your self antigens. And if these T cell receptors react with this SSA or SSB antigens, and you also have self-reactive B cells in the vicinity, right? Because they also escape central tolerance in your bone marrow, then what's going to happen, right? These self-reactive B cells, remember, B cells can also present antigens. So they can internalize these self-antigens via their B cell receptors, right? And then they can present that onto MHC2. And remember, in B cells, right, you also have so remember the interaction between your T and B cells, you also need that CD4 protein binding to MHC2. But remember, if you for in order for your B cells to get activated, you need CD40 ligand interacting with CD40. Once that interaction happens, your B cells get activated and start secreting antibodies. Antibodies against what? This antigen, right? And what was this antigen? SSA or SSB, which are self-antigens. So then if you start secreting antibodies, right? Because remember, your T cells can secrete what? Interleukin 4 and 5, right? And that can make your B cells class switch and produce antibodies. So once your once your B cells get activated, right, they can differentiate into plasma cells and start secreting anti-SSA and anti-SSB antibodies. And that's why you see anti-SSA and anti-SSB antibodies in Sjogren syndrome, right? That's why you can see these antibodies. Okay, but the thing, remember, the damage is not due to these antibodies, it's due to lymphocytic infiltration. It's a type 4 hypersensitivity reaction. So the damage is not due to the antibodies, it's due to the fact that you have lymphocytic infiltration. And because you have a lot of autoantibodies getting formed, you may form immune complexes. But what we should know is, right, the main source of damage that comes from Sjogren syndrome is due to your T cells infiltrating. Okay. So if you want to remember the main thing, right, it does not, these antibodies are not the primary source of damage that's occurring in this disease. All right. It's mainly from the T cells. Okay. So, so that's the important thing to know, right? And you may see immune complex formation, but the main thing that we should understand is that it's lymphocytic infiltration. Okay, so let's just try to remember the main things. So it's a type 4 hypersensitivity, infiltration of T cells, self-reactive T cells, and your anti-SSA and anti-SSB antibodies are diagnostic markers, right? If you to do a serology in the blood test, you would see these antibodies, which would help you diagnose Sjogren syndrome. But it's not directly causing tissue damage. Okay, it's the T cells, your self-reactive T cells that are causing the tissue damage. Okay, so let's talk about another main thing is that you can't, it's not, this disease doesn't only affect your salivary glands and lacrimal glands. It can affect other body systems, right? That's why we have extra glandular manifestations, manifestations outside your normal glands, like your lacrimal glands and salivary glands, okay? So remember we were saying that this is due to self-reactive CD4 T cells, right? That are infiltrating your glands and attacking them, causing them to fibrose and leading to dry eyes and dry mouth. But these self-reactive T cells can also infiltrate other tissues of the body, hence extraglandular manifestations. All right, so let's see how this works. So one body system that can be affected, right, in Sjogren syndrome is your skin. So you can have damage of the small blood vessels that supply your skin, right, leading to cutaneous vasculitis. Okay. And if you get cutaneous vasculitis, you can get something called palpable purpura, right? So let's see what we mean by that. So remember, we form autoantibodies, right? And these antibodies can form immune complexes and deposit in the walls of your blood vessels, right? Your small blood vessels that supply your skin, for example. And we know that when immune complexes deposit, right? So let's say if we just drew a simple diagram, right? Like this is a blood vessel, and we're just going to zoom in on the wall here, right? So we zoomed in on the wall there, and let's say that we have immune complexes that deposit here, right? Remember what happens next after immune complexes deposit? We get complement activation, right? And eventually we get the production of certain things like C3A and C5A, right? And we know this induces inflammation, right? It enhances inflammation and can attract neutrophils, right? And so when neutrophils come in, they can release things like reactive oxygen species plus proteases, which will do what, right? Which will damage the blood vessel wall. And if your blood vessel wall gets damaged, you can have red blood cells that leak out from your blood vessels into your dermis, right? So let's say this leads to red blood cells, right? Leaking out from your blood vessel wall and into your dermis, for example. Okay, so then you can get things like if red blood cells leak out, we know that can lead to s- purpura, right? So like you can have red purple spots. Okay, so that's a sign. Okay, there's blood vessel. I mean, there's blood leaking out of the blood vessel, right? So this can be certain. We can say certain defining features like this would be non-blanching, for example, right? Meaning if you pressed on the purpuric lesion, it wouldn't blanch, right? Meaning it wouldn't disappear. The red purple color wouldn't disappear because it's blood that's extravasated. Okay, it's out of your blood vessels. All right, it's not like a hemangioma, for example, where the blood's inside your blood vessels, and if you press on it, it would blanch. This is non-blanching because the blood's outside your blood vessels and into your skin tissue, right? So if you press on it, it won't blanch, meaning the red or purple color won't go away if you palpate it or press on it. And so what does this mean, right? So when we go back here, we said it was not only purpura, and we just said that, okay, it's non-blanching. But what does palpable mean and why is that there? So palpable, of course, means if you palpate the purpuric lesion, right, it's going to be raised. Okay. So it's going to be, we said it's going to be, you're going to see purpura, these red purple spots. We said it's going to be non-blanching, and we said it's going to be a palpable purpura, because if you palpate it, you'll feel it that it's raised. Okay. Now, why is it raised? Because this purpura is due to vasculitis, right? So you have perivascular inflammation, right? Due to the what? Immune complexes. So you have perivascular inflammation due to the immune complexes, and due to the vasculitis, right? You're going to have your blood vessels that will be inflamed. And if you have inflamed blood vessels, that can lead to palpable purpura, meaning you're going to have a raised lesion, right? So that's why it's palpable, because your blood vessels are inflamed. Okay. And so that's the cutaneous vasculitis skin finding. All right. So what are other skin findings that we can see? Right? We can see other skin findings like dry skin, for example, right? We can see dry skin, and then we can also see Raynaud's, right? We know we see Raynaud in a lot of autoimmune diseases, right? But we can also, one of those diseases that we see Raynaud in is Sjogren syndrome. Okay, so you can see palpable purpura, dry skin, Raynaud's. All right. And then that's for the skin mainly, right? And if we move on to another body system that can be affected due to Sjogren syndrome is your joints. You can see joint pain here, right? Or arthritis, right? But this is going to be, is this going to be erosive or non-erosive, right? It's going to be non-erosive, okay? Like you would see in lupus, for example, too. But where do we see erosive arthritis, right? Where do we see erosive arthritis? That's going to be rheumatoid arthritis, okay? So that's an important distinction to make too. All right, so we can see arthritis or arthralgia. You can even, your muscles can also be inflamed too. So you can see things like myopathy, right? Or myalgia, okay? So that's for your musculoskeletal. And another important organ to know, right, is in Sjogren syndrome, you can have interstitial lung disease, all right? So if you have interstitial lung disease, right, how would this happen? Well, remember, we said you have self-reactive T cells that can infiltrate your lung tissue, right, and release interleukin 17. This can attract neutrophils to that area. Neutrophils release damaging things like reactive oxygen species and proteases, which can damage your lung tissue and inflame it. And we know over time, chronic inflammation like this can lead to fibrosis. If you get fibrosis of your lung tissue, that can lead to interstitial lung disease, which is a restrictive lung disease, right, due to fibrosis and all the lymphocytic infiltration of your lung interstitium. And then, of course, if you have interstitial lung disease and fibrosis of the wall of your lungs, right, then that's going to impair your blood oxygen, or that's going to impair oxygen flow, right, and that can lead to impaired oxygen, or that can lead to low amounts of oxygen binding hemoglobin, right? So remember, in restrictive lung disease, if your lung wall is fibrosed, then you won't be able to fully inhale. If you can't fully inhale properly, you can't get the proper amounts of oxygen in, which means you may have low oxygen levels in your blood. All right. So we have to remember, we'll talk about interstitial lung disease and restrictive lung disease, obstructive lung disease, all of this in the pulmonary playlist. But if we quickly mention it here, remember in restrictive lung disease, right? One of the causes being interstitial, or one of the causes being fibrosis, right? Which can lead to interstitial lung disease. So in restrictive lung disease, what findings do we see, right? So remember, we have our FEV1 and FEV1 over FEVC, right? FVC. So the FEV1 FVC ratio is going to be, will it be greater than 80% or less than 80% in restrictive lung disease, right? So let's see what it's going to be. So remember, the amount of air you blow out in 1 second is your FEV1, right? And so remember, in restrictive lung disease, you can't inhale fully, right? So that means the total amount of air you inhale isn't going to be that much, right? So then you can't therefore exhale a lot of air, right? Because you don't have much of a lung volume, you have a small total lung volume. So if you can't inhale much air, then you can't exhale much air in this disease because your lung wall is fibrosed. So then that means your FEV1, right, the amount of air you can exhale forcefully in 1 second is going to be low. And what's your forced vital capacity, right? It's how much air you exhale, the total amount of air you exhale, right? In your 4 or 5 seconds, in your 5 seconds that you do that happens in this test. Because remember, in this test, also called the pulmonary function test, right? Remember, we in this forced spirometry test, right? We measured the lung capacity. Okay, so you breathe in as much as you can, right? And then you breathe out forcefully, right? And in the first second, the amount of air you breathe out, right? That's your forced expiratory volume, right? Your FEV in 1 second, so your FEV1. And your forced vital capacity is the total amount of air you exhale, right? During this test. So over your entire duration of your exhalations, basically the total amount of air you exhale during the whole time you exhale. Okay, so your FEV1 is the amount of air you exhale in 1 second, and your FVC is the total amount of air you exhale due to that breath that you took. So in restrictive lung disease, you can't inhale much air because your total lung volume is small. That means you can't exhale much air, so your FEV1 is low. And then remember, we said you can't inhale much air in the first place, right? Because your lung walls are fibrosed. That must mean your forced vital capacity will be low because you won't have much air to blow out, right? In this test that we do, the pulmonary function test. So that means your FVC would also be low. But it turns out in restrictive lung disease, your FVC is lower than your FEV1. And if the denominator is lower than the numerator, right, the lower the denominator is, the higher the overall value of the ratio is. That's why we see in restrictive lung disease, the FEV1 over FVC ratio is greater than 80%. Okay. And then what do we say our lung capacity looks like? Your total lung capacity we can expect to be low, right? Because you can't inhale much air in restrictive lung diseases. So your total lung capacity will be low also. All right. And then we're going to have a greater than 80% FEV1 over FVC ratio. Okay. And another important thing to know is that in interstitial lung disease, remember we have our diffusion capacity, right? Or diffusing capacity for carbon monoxide, right? What is that called? That's your DLCO value, right? So what is this? This is your diffusing capacity of the lung, right? For what? For carbon monoxide. So the way what this test measures is, right, is how your alveolar surface area is, how your membrane thickness is, right? How much volume do your pulmonary capillaries have, right? So why is this test good, right? Well, if this test comes out low, right, there could be many reasons for that. If your DLCO value is low, right? So first of all, what is this measuring? It's measuring how well gases can diffuse from your alveoli to your blood vessels, right? So remember, you have your alveoli here, and then you have your capillaries here, right? So if you have a low DLCO value, that means you're not the proper amounts of gases are not going from your alveoli to your blood vessels, right? So why can that happen? Well, if your alveoli surface area is all messed up and you don't have good surface area, then proper amounts of gases, right, which I'll represent as oxygen, cannot diffuse through. So one thing that can affect your DLCO value is alveolar surface area, right? And what if this membrane is super thick, like we see, like we can see it's interstitial fibrosis? Then that's also gonna impair proper diffusion of gases, right, from your alveoli to your blood vessels. So another important factor that can affect your DLCO value is membrane thickness, right? What if the amount of blood coming from the right side of your heart isn't that much, right? You just don't have much blood coming. So your perfusion is low, right? So you don't have much blood coming from your right side of your heart. So you have low perfusion. Well, if you have low perfusion, then what does that mean? Your DLCO value be low because remember, what is that measuring? Your DLCO value is measuring how well gases can diffuse across your alveolar capillary membrane, right, in your lungs. If you have low perfusion, right, going to your alveoli, then you don't have much blood volume, which means you don't have much oxygen, which means you don't have much not so the oxygen that's present in your alveoli, right? So if you have a lot of oxygen present in your alveoli, but you have low perfusion, right? Why would that lead to a low DLCO value? Well, if you have low perfusion, then you also have low red blood cells come into the area, and you have low a low amounts of total hemoglobin coming, right? Because you have low number of red blood cells arriving to your alveoli because of low perfusion. So if you don't have that many red blood cells, then oxygen, right? All this oxygen in your alveoli don't have many red blood cells to bind to, which can decrease your DLCO value. Okay. So low perfusion can lead to a low DLCO value. And what other conditions can we see low perfusion in, right? Like for example, why would we see low perfusion? What if we have a pulmonary embolism, right? So remember, let's say there's a clot, right? So if we draw the right side of the heart here, let's say this is your right ventricle, and it's sending blood up, right, to your lungs, let's say through this blood vessel. What if we have a clot right here, right? That's gonna severely decrease perfusion, which means you're gonna have low red blood cells for the oxygen. You're not gonna have many red blood cells, I should say, for all these oxygen molecules to bind to, right? And so that's gonna lower your DLCO value. Okay. What if you had pulmonary hypertension, right? So what if your pulmonary artery, right, has a lot of atherosclerosis, for example, right? And you have and not much blood, right, can go through, or your pulmonary artery is severely clamped down, right, right, and that leads to less blood going through. Any of these reasons will lead to a decrease in capillary perfusion, right, which going to your alveoli, which means low amounts of red blood cells, which means oxygen won't have that many red blood cells to bind to, right, once it diffuses across the alveolar wall. What if you have anemia, right? So you have normal perfusion, but you don't have much hemoglobin in your red blood cells, right? Due to iron deficiency, let's say. So if you don't have much hemoglobin in your red blood cells, but normal perfusion, that's still going to decrease your DLCO value because less oxygen, or your oxygen in your alveoli won't have much hemoglobin to bind to. So that's going to also decrease your DLCO value, right? Or what if your right ventricle for some reason can't pump properly, right? Maybe maybe your the nerves that supply, right? Remember so we have our AV node, bundle of His, and then your Purkinje fibers, right? What if those aren't functioning properly? Or what if you have a coronary artery, right, that was supplying your right ventricle? What if that coronary artery gets blocked and your heart muscle dies, right, in your right ventricle? Therefore, your right ventricle can't pump properly, which means low blood flow to your lungs, right? There's many reasons why your right ventricle can stop working, right? And that can lead to poor perfusion to your lungs, and which can lead to low DLCO value, right? So there's many reasons that can lead to a low DLCO value. We went off on a tangent, but we'll talk more about this when we do our pulmonary playlist, right? For interstitial fibrosis and restrictive lung diseases. But that's important to know, okay? So what do we have here? We said that in interstitial lung disease, right? We see if we have low surface area, for example, right? Or we have low perfusion, right, to our lungs, then we can see things like a low DLCO value, right? Or if our membrane is really thick, we can see a low DLCO value, as we see in interstitial fibrosis, and we see interstitial lung disease, right, in Sjogren syndrome. Okay, so we went off on a huge tangent. Sorry about that, but that's some cool stuff, right? That's important to know for interstitial lung diseases, right? When we're talking about the DLCO value. Okay, and just looking at this right now, surface area will affect, right, impair proper flow of oxygen from your alveoli to your blood vessels. Where do we see low surface area, right? We can see that in emphysema, right? COPD, where you destroy your alveoli, which can lead to a low surface area and impair proper flow and diffusion of gases like oxygen from your alveoli to your blood vessels. Okay, but we'll talk about that when we do the pulmonary playlist. Okay, so that was a huge tangent, my bad. But let's keep on talking about Sjogren syndrome, extraglandular manifestations. So we have interstitial lung disease, and we just talked about that a lot, right? That we can see. And let's move on to the kidneys now. So in the kidneys, we can have things like interstitial nephritis, right? And we can also see things like type 1 renal tubular acidosis, right? And what is that? So we're going to talk about this in our renal playlist too, but if we just quickly talk about this right now, remember remember our collecting ducts, okay? So if we just zoom in on a collecting duct cell like that, and then we say on this side is our tubule, right, of our kidneys. So this is going to be where urine is, and then let's say that this side is where our blood vessel is, where we absorb some stuff, right? And what happens is in our collecting duct, right, we have certain we have certain types of tubular cells. One of those cells are called alpha intercalated cells. Usually what happens if your blood gets too acidic, for example, right, what these alpha intercalated cells do is, let me just change this color. If your Let's say your blood gets too acidic, right? What would you want to do? You would want to make it not acidic, right? Make it more alkaline. So your kidneys play a huge role in balancing pH. So if your blood gets too acidic, I would want to put something like bicarbonate in there because bicarbonate brings your pH up, right? It's alkaline in nature. So on the basolateral surface of your alpha intercalated cells, remember this is in your collecting duct, right? You have a certain channel. What does this channel do? It takes bicarbonate and puts it into your blood, and it takes chloride from your blood, puts it into your alpha intercalated cells. Because if you're taking out a negative charge from your cells, you want to restore that charge balance, right? So if you're taking out a negative charge, you want to put a negative charge in. We do that with the help of chloride anion, right? So that's what happens to balance the pH. But what else happens, right? On the other side, right, we have another channel that's highly important. So we have one channel that's a proton ATPase, a hydrogen proton ATPase, right? So what this channel does is it takes hydrogen protons and it pumps it into your urine, right? And it does this via the help of ATP. And then you also have another channel, right, that takes hydrogen protons, let's write that better, that takes hydrogen protons and pumps it into the urine, right? But it also takes potassium from your urine and pumps it into your alpha intercalated cells. Normally, this is what happens. So, like, let's say your blood is really acidic, right? So, normally, if you have CO2, right, in your blood, that can diffuse across, and we can take that CO2, right, combine it with water, for example, and form carbonic acid via the help of carbonic anhydrase, right? H2CO3. And then we know that H2CO3 or carbonic acid, right, can then break down into hydrogen protons and bicarb. And this bicarb, right, can then go into this channel. And then this hydrogen proton can go into either one of these channels, right? In Sjogren syndrome, what can happen is you can get infiltration, right? T cell infiltration, which can damage your alpha intercalated cells. So this can lead to damage of your hydrogen proton ATPase, damage of your hydrogen potassium channel, or damage of your bicarbon chloride channel, right? So if we took an example, let's say this channel got damaged in Sjogren syndrome. If this channel gets damaged, right, then what's going to happen? Let's just follow it. What does this channel normally do? It takes hydrogen protons and puts into your urine, and takes potassium from your urine and puts into your alpha intercalated cells, right? So if this channel is damaged, then you can no longer do this. So you can't acidify your urine, right? Because we know hydrogen protons are what? They cause your pH to drop. They acidify things, right? hydrogen protons are acidic. If you can't if you can't put hydrogen protons, right, into your urine, you can't acidify your urine. So you can see alkaline urine in type 1 RTA. And then if you can't take potassium and put it into your alpha intercalated cells, right, then you're going to lose potassium in your urine, leading to hypokalemia, right? Hypokalemia, low blood potassium levels. Another reason why you have hypokalemia, which is kind of interesting, is because you can't no longer put protons into your urine. What your kidneys try to do is they balance the charge, right? If you can't put positive charge anymore, right, your hydrogen protons into your urine, what it does is it compensates by putting more potassium into your urine because potassium is positively charged. So in your principal cells, right, let's say we draw our principal cells right here, in your distal convoluted tubule, for example, in your principal cells, due to the inability to transfer hydrogen protons into your urine, your principal cells have sodium potassium ATPases, right, on the surface near the blood vessels. And then they also have sodium channels here, right, where sodium goes from your urine into your principal cells and out through the sodium potassium ATPase into your blood, right? And we know potassium comes through the sodium potassium ATPase, and we have a channel on this side so that potassium can go into your urine. And remember, this activity, right, increases in your distal convoluted tubule of your principal cells via the exposure of aldosterone. But what happens in type 1 RTA, because you can't acidify your urine anymore, to balance out, to compensate for the loss of positive charge in your urine, you upregulate the sodium potassium ATPase, which leads to more potassium going from your blood into your principal cells and from your principal cells into your urine. So it's just to balance out the positive charge. But this leads to low blood potassium levels. Okay, so you can see hypokalemia. I don't know why I just pronounced it like that. Hypokalemia, right? Which is low blood potassium. You can see alkaline urine because you can't take this hydrogen proton and put it into your urine, so your pH of your urine goes up, right? And hypokalemia is also seen too. And if in Sjogren syndrome, let's say this channel is not working, then of course you can't put bicarb into your blood, right? So what happens is because of the inability for these channels to function, right? If you can't put hydrogen protons into your urine, we can see then that means hydrogen protons can start to leak out into your blood. What if this channel is not working, as you can see in Sjogren's, that means you can't put bicarb into your blood either. So if you can't put alkaline things into your blood, or if acidic things are leaking into your blood, then you see metabolic acidosis. All right. So you can see metabolic acidosis. And we'll talk about this more when we do the renal playlist, but specifically, this would be non-anion gap metabolic acidosis because there is no your anion gap is normal. Okay. So your anion gap is normal. All right. So maybe that was a too long of explanation, but that's what type 1 RTA basically is. Okay. And we'll talk more about this in the renal playlist. All right. So let's get back to Sjogren syndrome. So as we said, this can lead to low blood pH and hypokalemia. Okay. You can also see things like peripheral neuropathy, especially if you get damage of blood vessels that supply your nerves. Remember, we said that vasculitis is one extraglandular manifestation because of immune complex deposition. What if you get damage of blood vessels that supply your nerves? You can get peripheral neuropathy, right? And you can even affect certain nerves like your trigeminal nerve, right? So you may see like loss of sensation in certain areas of your face. Okay. So another thing we can see is cranial neuropathies, like if your trigeminal nerve gets affected, then you can see things like facial numbness, right? And so that's basically for nerves, right? And then of course, a really important thing to know, okay, for Sjogren syndrome is that you have an increased risk of marginal zone lymphoma. Okay, so it's a non-Hodgkin lymphoma, and we'll talk about this when we talk about lymphoma, right? Specifically. But marginal zone lymphoma, right? How did this occur? Well, remember we said one of the glands that can be affected is your parotid glands, right? Because they secrete saliva. Now, if you're continuously getting CD4 T cells that are infiltrating, right, your salivary glands, right, what that can do is that can start to stimulate your B cells, right, in your salivary glands. And if you continuously and over time chronically keep on stimulating your B cells in your salivary glands, right, they can start to form germinal centers like you'd see in lymph nodes. Okay, and remember what's a zone in your lymph node, for example, or your spleen that you can see, right? So your marginal zones. Remember, you have your, if we just draw a quick diagram here, right? You have your follicle area, right, in your cortex that we're talking about. You have your follicle area, then you have your mantle zone, and then you have your marginal zone, right? In your marginal zone, you have memory B cells, okay? You have memory B cells, and for example, you can see marginal zone in your spleen, for example. But if you continuously keep on stimulating your B cells in your parotid gland, for example, right, they can start to form germinal centers. And if you continuously activate your B cells, like you would see in Sjogren syndrome, you can you make more and more memory B cells. And where did we say memory B cells sit? Your marginal zone. And if you keep on stimulating B cells, you're going to keep on making memory B cells, and memory B cells will accumulate in your marginal zone. And the more you accumulate these memory B cells, the more increased chance you have of mutations forming, which can then lead to malt lymphoma, right? Or marginal zone lymphoma, okay, which is the malt lymphoma subtype. So, see, that's how you get marginal zone lymphoma because you start to you stimulate your B cells over and over and over, right? So your B cell, you make more and more memory B cells, and as your memory B cells keep on accumulating, you have an increased chance of forming mutations in your memory B cells, right? Which can lead to B cell lymphoma or marginal zone lymphoma because you get cancer of your B cells that are in your marginal zone in your parotid glands. So that's why after a while, if you start to see parotid gland enlargement, that can be a sign for marginal zone lymphoma. Okay. So of course you can also see lymphadenopathy, right? Because your lymph nodes, this Sjogren's can also affect your lymph nodes. And then you can make antibodies against your red blood cells, white blood cells, and platelets. Therefore, you can see things like anemia, leukopenia, thrombocytopenia, right? And if your esophageal mucosa dries out, like you can see in Sjogren's, you can see esophageal dysmotility, right? Even and dysphagia, okay? And and then of course another important finding, right, in Sjogren's, you can get lymphocytic infiltration of your bile ducts. All right. So if you see lymphocytic infiltration of your bile ducts, that can lead to primary biliary cholangitis, right? So that's basically if your what is that? So that's basically if your lymphocytes, right, can infiltrate your bile ducts, your intrahepatic bile ducts, leading to fibrosis and inflammation of those bile ducts, right? That happens for long enough, this can lead to something called cirrhosis, right? This can lead to cirrhosis, so scarring of your liver, damage of your liver. And of course, we'll go over this when we talk about or when we do our GI playlist, right? So we don't have to go in depth into this, but of course you can see things like elevated liver enzymes, right? Like GGT or elevated ALP, right? You can also see, like, remember your bile ducts do what? They take bile and put it into your intestine so you can digest fat, right? And they're responsible for making your stool dark colored. So if you can't do that, you can see pale stool, right? You can see steatosis, right? Or steatorrhea. My apologies, steatorrhea. You can so basically you can won't be able to digest fat properly, right? So you can see increased fat in stool, right? And so on, right? There's so many different findings that you can see due to your bile ducts being inflamed, right? You may even get pruritus because if your bile ducts are inflamed and fibrosed, right, you can leak bile contents into your blood, like bile salts, for example, and bile acids, which can lead to pruritus or increased itching, right? So, so that's we're not going to go like full in depth into this, but that's some things you can see. And another like just quick is that you can also have AMA, right? Anti-mitochondrial antibodies. And this distinct from, remember, this is different from primary sclerosing cholangitis, because that's when you get inflammation and fibrosis of your intrahepatic and extrahepatic bile ducts, okay? And that's associated with ulcerative colitis. Remember that too, and P-ANCA. Okay, so but we'll talk about all this in the GI playlist. All right, and then of course in Sjogren syndrome you also have an increased risk of atherosclerosis, right, which can lead to many adverse events, as we know, like stroke or heart attack, for example, and ischemia. Okay, and then of course there's certain associated conditions that you see in um, Sjogren syndrome, right? So some associated conditions that you can see is lupus, right? Rheumatoid arthritis, and then of course Sjogren's, right? And it turns out you can even see another associated condition, which is Hashimoto's, right? So you can get destruction of your thyroid glands, right, which can lead to hypothyroidism, right? And then, of course, we said also you can see things like marginal zone lymphoma, right? B-cell lymphoma, the MALT type, so MALT lymphoma, affecting your parotid glands, right? So basically, these are the types, these are the associated conditions for Sjogren's, okay? And those are the main extraglandular manifestations that we should know. Okay, so let's move on, because I know that this video is getting way too long, so my apologies. So what are the main antibodies that we see then? We see ANA, right? We see anti-SSA, anti-SSB, okay? And then another antibody to be familiar with is we can see rheumatoid factor, okay? And now rheumatoid factor can also be seen in rheumatoid arthritis, but it turns out rheumatoid factor can also be seen just in Sjogren syndrome, even though the patient doesn't have rheumatoid arthritis, okay? So these are the main antibodies to know. An important thing to know, though, is the anti-SSA antibody and anti-SSB antibody have the ability to cross the placenta and go to the fetus. When that happens, that increases the risk of certain things like rash, inflammation of your liver, and congenital heart block. Okay, so it's important to remember this also, so you can screen pregnant women, right? If the patient's pregnant, you can screen them for anti-SSA and anti-SSB antibodies. You can also see these antibodies in lupus too, okay? So that's important to know too. And last but not least, let's talk about a certain finding that you can do if you do a lip biopsy, right, of your minor salivary glands, because remember your minor salivary glands are present in your lips too, okay? And if you do a biopsy, you can find something that's important to remember this. You can find dense lymphocytic infiltrates in your minor salivary glands, and this and the finding of the dense lymphocytic infiltrates, right, is called focal lymphocytic sialadenitis, okay, inflammation of your minor salivary glands, okay, due to lymphocytic infiltrates. All right. So I know this was a way too long of a video, but that's basically what Sjogren syndrome is. Okay. I hope this video wasn't way too confusing. I hope it made a little bit of sense, helped even a little bit. Thank you guys for watching, and see you guys in my future videos.